Today we are going to discuss about management of STEMI, especially the antiplatelet and anticoagulant part. Now we know ST elevation MI. We can either go via three mechanisms for its treatment. One is we can go for fibrinolysis, or for example PCI. Sometimes post fibrinolysis patient can also go for this PCI. Third is when neither of the two can be done. That's where we say no reperfusion therapy was initiated. Now we have to discuss about antiplatelet and anticoagulant therapy. Antiplatelet therapy, now we know that we have to use oral antiplatelet. For example, especially we have to deal with these three cases, above mentioned three cases. Patients who have been treated with fibrinolysis, they had to receive loading dose of clopidogrel or clopidogrel 300 mg if age is greater or equal to 75 years. But if it is less than or equal to 75 years, but if age is greater or equal to 75, then you have to load them with clopidogrel 75 mg in addition to aspirin. So if a patient who is 80 year, for example male, who developed ST elevation MI, then you have to load them with aspirin and clopidogrel. Clopidogrel you have to give only 75 mg in that case. Whereas patient who have not been these patients who have not been treated with reperfusion therapy, then there you have to give this ticagrelor. You have to load them with ticagrelor 180 mg. Now, third scenario is patients who have been treated with PCI or primary PCI. You can give them high dose or potent oral antiplatelet agents, that is either with this ticagrelor 180 mg or prasugrel. You can give them a 60 mg. You can give them these medications if there is no contraindication. For example, contraindications like prior stroke, or patient has prior history of TIA. Also, there are other relative contraindications for prasugrel, like if patient has weight less than 60 kg, these are relative contraindications, and if patient has age 75 or more, then these are the relative contraindications, but these are the absolute contraindications for initiation of prasugrel in cases of patients who have been treated with PCI in ST elevation MI. So if these potent, for example, these two potent antiplatelets cannot be used, then we have to switch them with clopidogrel 300 mg. Because these are potent, then meets the contraindications for these two, ticagrelor and prasugrel, will be obviously when patient has high risk of bleeding. Similarly, we have this for anticoagulation as well. That is, patients treated with fibrinolysis, patients treated with PCI, patients who have not received any reperfusion therapy. We'll discuss them separately. So, anticoagulation therapy in patients with ST elevation MI who have undergone fibrinolysis. So here, what we do is first we'll discuss PCI patients. So patients who have been treated with primary PCI, we prefer either UFH or bivalirudine. So This recommendation assumes that patients will receive a potent oral antiplatelet ticagrelor or prasugrel. So, with PCI, patients can receive anticoagulation in the form of either UFH or bivalirudin. There are indications. UFH will be given to patients who have received potent oral antiplatelet agents with ticagrelor or prasugrel. That is prasugrel of 60 mg and ticagrelor of 180 mg. If they have received these potent antiplatelets, then only you will go for UFH in case of patients who have received PCI as the primary modality of treatment in case of ST elevation MI. Whereas bivalirudin is given only when we had contraindications for ticagrelor and prasugrel, and patients received clopidogrel 300 mg in addition to that of aspirin. Then only patient will receive bivalirudin as anticoagulant in patients who have undergone primary PCI as primary modality of treatment for ST elevation MI. Now, dosage of this UFH. Dosage of UFH is an initial. If we go for UFH dosage, then initial dosage is 50 to 70 units per kg. We give up to a maximum of 5,000. 5,000 these units we give subcut. Additional heparin may be given in the catheterization laboratory based on the results of the ACD monitoring, whereas bivalirudin initial dose is 0.75 mg per kg, followed by IV infusion. So if a patient has, for example, 60 or 70 or 100 kg, 0.75 mg we have to give. That means 75 milligrams of bivalirudin is given in a case of 100 kg person weight, followed by infusion of 1.75 mg per kg per hour, which can be discontinued after PCI. And now in case of patients who have this undergone fibrinolysis, we prefer enoxaparin for patients not at high bleeding risk. So we categorize patients at high risk of bleeding, patients at low risk of bleeding. If a patient is at high risk of bleeding, then we use fondaparinux. But if a patient is at low risk of bleeding, then we use enoxaparin. For those patients in whom PCI is possible or likely after fibrinolytic therapy, UFH is reasonable. That means if, for example, post fibrinolysis, you are planning the patient for PCI, okay, then in such case anticoagulant has to be switched from this either fondaparinux or enoxaparin to non-fractionated heparin post PCI. So if we go towards the dosing of this enoxaparin given in patients with low risk of bleeding, now it depends whether the age is less than 75 or greater than 75. So less than 75, then you have to give 30 mg IV bolus. You have to give, followed by 1 mg per kg subcutaneously BD. That means 60 mg BD. I can give it up to a maximum of 100 mg for the first 2 subcutaneous doses, and the first subcutaneous dose should be administered with the IV bolus. Note that in patients with age greater or equal to 75, here there is no IV loading dose. Whereas fondaparinux dose is 2.5 mg IV followed by 2.5 mg subcutaneously OD. So initially 2.5 IV, then 2.5 subcutaneous OD you can give. And this drug, fondaparinux, fonda is avoided if creatinine clearance is less than 30 ml per minute. And now, for those patients who have not received any reperfusion therapy, we give either enoxaparin or unfractionated heparin. So one thing you have to take note on this most potent antiplatelets that we use in, for example, ST elevation MIR. Those this ticagrelor 180, prasugrel 80 mg. So the contraindications for using prasugrel in patients is, for example, past history, prior history of stroke or TIAs, or related contraindications like greater than or equal to 75 years of age or weight less than 60 kgs. In these cases, if a patient, so I can frame a question, a patient ST elevated MI who has undergone primary PCI, is who has a past history of stroke or TIAs and age is, for example, 90 years and weight is 40 kg, wants to be put on potent antiplatelet. So which antiplatelet will you not prefer? Answer will be directly prasugrel. Prasugrel 8 mg is not required here. In place of that, you can give ticagrelor or clopidogrel, but it is safe to go for clopidogrel. But if you have gone for clopidogrel here, then in anticoagulation part, you will give what? You will obviously give them bivalirudine.